Hello, I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor here and I'm focusing on genitourinary cancers. I have been leading the genitourinary cancers program here over the recent years, and have been focusing in bladder cancer, and now I transition leadership to a great colleague of mine, taking over new roles as an international program and regional outreach. And at the same time, I'm very excited about the amazing data we have seen in ESMO 2025. And I want to have the opportunity to answer some great questions by colleagues globally who pose those questions in anticipation of the data at ESMO 2025. I will start the first question by Dr. Rossi in Italy. Dr. Rossi is asking for patients with muscle-invasive bladder cancer who are eligible for cisplatin, how are we integrating perioperative immunotherapy into the treatment pathway after the recent data updates? That's a great question, Dr. Rossi. I would say that it depends, for now at least, based on the currently available data, on whether we treat the cisplatin eligible patients. As we pointed out, the data from the Niagara trial is the standard of care with level 1 evidence. Just very briefly to remind the audience, the Niagara phase 3 trial evaluated the addition of perioperative durvalumab, anti-PD-L1, to the neoadjuvant GemCis in patients with localized muscle-invasive bladder cancer who are eligible for cisplatin, and showed increase in the pathological complete response rate and significantly longer event-free survival and overall survival. So there is benefit with the addition of perioperative durvalumab. Durvalumab in that trial was given together concurrently with neoadjuvant GemCis for 4 cycles, and then continued adjuvantly with 8 monthly doses of adjuvant durvalumab, and this was regardless of the pathologic stage or ctDNA status per trial design. So of course there are many nuances and discussions whether we need the adjuvant phase of treatment. For the moment, I would say until we have more data and subset analysis in the future from this and other trials, I tend to use both neoadjuvant and adjuvant durvalumab in that context, based exactly on the Niagara trial design. And based on the subset analysis we show at ASCO 2025, there appears to be separation of the curves even in the subsets of patients with negative ctDNA post-cystectomy and with and without PathCR. So I tend to continue the adjuvant durvalumab, these 8 monthly doses, as long as there is no major side effect, of course. Now, of course, we saw data at ESMO 2025 with EV303 Keynote 905 trial. That trial evaluated the perioperative use of Pembrolizumab and enfortumab vedotin, Pembro EV, both neoadjuvant, 3 cycles, and adjuvant, 6 cycles combination EV Pembro, and then 8 cycles additional, subsequently Pembro alone. That trial showed significant increase in the pathological complete response rate, 57% in the all-comers, 65% in the subset of patients with cystectomy, and showed significantly prolonged event-free overall survival. And again, the control group, it was only radical cystectomy with no perioperative therapy. And this was for cisplatin ineligible patients, specifically the EV303 trial. So again, the Niagara is for cisplatin eligible patients, EV303 for cisplatin ineligible patients. However, there is some overlap because Niagara allowed patients with GFR 40 ml per minute or higher. So there is some overlap between the 2 studies in this population. So overall, I think those 2 trials are the best data sets we have seen in the localized MIBC setting, muscle-invasive bladder cancer. Again, depends on cisplatin eligibility and the reasons for that. And I think, as I mentioned, Niagara and EV303 are important trials. Of course, there are many more trials ongoing. There are trials looking at GemCis plus minus Pembro, GemCis plus minus Nivo, and of course we have the EV304 or Keynote B15 trial with Pembro EV versus GemCis neoadjuvantly being compared, and the Volga trial evaluating enfortumab vedotin plus durvalumab plus minus tremelimumab. That's an interesting trial in cisplatin ineligible patients. So all those trials are going to define further the role of perioperative therapy. We have, of course, adjuvant trials like the modern trial with Alliance in US that is evaluating 2 different questions in the adjuvant setting. Many more, of course, to discuss, but I want to give you a broad overview for this great question. Another great question was by Dr. Martinez in Mexico. Dr. Martinez is asking, when treating metastatic urothelial carcinoma, how do we decide between continuing immunotherapy versus switching to a different mechanism, either drug conjugates like enfortumab vedotin or trastuzumab govitecan? It's a great question, Dr. Martinez. I think it depends on what treatment you start with. When enfortumab vedotin plus pembrolizumab EV-Pembro combination is available, that EV-Pembro is the preferred frontline standard of care regimen in patients with metastatic urothelial carcinoma. Of course, in some countries there may not be access or reimbursement to EV-Pembro. Of course, that's an important issue that hopefully will be addressed globally for access to that patients should have access to these regimens. I think the question here is, if you, let's say, you don't have access to EV-Pembro and you start with platinum-based chemotherapy, and if someone has, let's say, a scenario, upfront progression, primary progression, which is not common with, let's say, Gemcis or Gemcarbo, and that patient do not get maintenance avelumab, as per Javelin Bladder 100 trial, or if the patient did not get Gemcis Nivo, if this is not available, or the patient was not cisplatin eligible, that patient who had platinum refractory disease, then they have the option to go to a second line checkpoint inhibition or enfortumab vedotin or erdafitinib if that's available based on FGFR3 mutation or fusion. I would say that this second line treatment decision for platinum refractory immunotherapy naive patients is a great one. I think it depends on the site of metastasis. Antibody drug conjugates like enfortumab vedotin have a very high response rate, and if you need to go for a response like liver disease, lung mets, bone mets, you may go with an agent with higher response rates like enfortumab vedotin. Of course, we have erdafitinib in those cases with FGFR3 mutation or fusion that is approved in the US, but this is after immunotherapy. Erdafitinib specifically, the approval is after immunotherapy, assuming immunotherapy can be given. And of course, the selection is depends on the patient, medical comorbidities, performance status, organ function, prior therapies, and tumor next generation sequencing NGS. If we take a scenario that patient already is on immunotherapy, Gemcis Nivo, Percheckmate 901, or EV-Pembro, which is a preferred frontline regimen, in that scenario, the immunotherapy continues for up to 2 years of trial design, unless there was any major progression or unacceptable toxicity. So the question is, what do you do? If the patient has progression, you probably switch. I would personally switch to a different mechanism of action if the patient is progressing while on immunotherapy. There are certain scenarios where you have immunotherapy that may stop because the patient decided so, like a treatment break, or because of a complete response. Or because of patient preference, or because of a significant toxicity, or because you stop 2 years of treatment. In either scenario, re-challenge with immunotherapy, it's an interesting question. We have data by Dr. Koskin with data from the Pembrolizumab trials, Keynote 45, Keynote 52, and Keynote 361 trials that develop Pembrolizumab. And Dr. Koskin showed that if in that scenario that you have prior checkpoint inhibition, you have no progression while on immunotherapy, and then you have a treatment break for whatever reason, and then you progress later, you may have a 41% response rate, 82% disease control rate with rechallenge of checkpoint inhibition. So it's an individualized decision whether you go back to immunotherapy in that context of previous discontinuation for no progression, or if you switch to a different mechanism. I think it depends also how much in the response, symptoms, bulky disease, site of metastasis, all those play a role in the therapy selection. And we do not know perfectly what is the optimal sequence in metastatic urothelial carcinoma. The last point I would say is we don't know the optimal sequence, and we do not know the optimal duration of immunotherapy. Do we stop at 2 years? Do we continue? I think it's individualized based on the patient decision and case-by-case scenarios based on informed and shared decision making. Long answer, because there are multiple different scenarios when you have, start with immunotherapy like EV-Pembro, preferred regimen, or Gemcis Nivo, or the maintenance avelumab scenarios. All these are different scenarios and may apply differently in different patients. Dr. Nair from India is asking a great question. In clinical practice, we often see patients who may have progression on platinum-based chemotherapy and checkpoint inhibition. What are the most promising targets or combinations on the horizon for this setting? A great question as well. I touched upon a little bit in my previous answer, Dr. Martinez. There are, of course, many antibody-drug conjugates, and I'm going to add here that in terms of antibody-drug conjugates, we have the enfortumab vedotin, antibody-drug conjugates, again, Nectin-4, carrying the MMAE payload. We have trastuzumab deruxtecan in the US, based on the HER2 3+ immunohistochemical expression, based on the gastric cancer scoring system that is available for those HER2 3+ IHC, that is available in metastatic urothelial carcinoma after prior therapies. And sacituzumab govitecan is not FDA approved anymore because it did not meet the primary endpoint of overall survival in the TROPiCS-04 trial that we published in Annals of Oncology last year. However, it's still listed in NCCN guidelines, sacituzumab govitecan. If someone used sacituzumab govitecan, that antibody-drug conjugate against TROP2, carrying the SN38 metabolite of irinotecan payload, that's sacituzumab govitecan, that drug should be given with primary prophylaxis of growth factor, GCSF, as primary prophylaxis to reduce the risk of febrile neutropenia and sepsis. So we have many antibody-drug conjugates. We have target therapies. I mentioned a minute ago about erdafitinib. That's an FGFR inhibitor for patients selected based on mutation or fusion in FGFR3, fibroblastic growth factor receptor 3. And again, this is based on tumor next generation sequencing. NGS, and this should be done at the time of diagnosis of metastatic disease, so you have the results available later for subsequent line of therapy. I tell patients the tumor next generation sequencing and immunohistochemistry for HER2 may not impact usually my first line treatment, but may impact subsequent lines of therapy. Of course, if we have clinical trials like with anti-HER2 antibody-drug conjugates, we have frontline trials, so HER2 testing may become relevant in those clinical trials, but outside clinical trials, tumor NGS and HER2 IHC impact subsequent lines of therapy, but I want to get it done as soon as possible in the frontline setting at the time of diagnosis of metastasis. And of course, there are many other targets and interesting biomarkers happening. So stay tuned for more trials, emerging targets in this setting with bispecifics, potential cellular immunotherapy, other targeted therapies. There is a lot going on in the field. Talking about interesting data, Dr. Leclerc from France is asking another great question, which is about my approach to using molecular profiling in bladder cancer. When do you test, and how much does this influence my practice? I just thought about that great question, and I was thinking that it's great to do the molecular testing, tumor next generation sequencing at the time of diagnosis of metastatic disease. So when the patient has locally advanced, not resectable, advanced or metastatic disease, get the tumor tissue for next generation sequencing, make sure that the FGFR3 mutation and fusion rearrangement is part of the next generation sequencing panel. And also I send immunohistochemistry for HER2 using the gastric cancer scoring system. And I use that as this great question is asking, at the time of diagnosis of metastatic disease, to have it available. As I mentioned, there are many clinical trials, even in the frontline setting, that uses, these molecular data biomarkers for clinical trial enrollment. And that's, of course, in addition to how we use this in clinical practice overall outside the trials. And the last but not least question comes to Dr. Khalid in the United States. For patients who receive enfortumab vedotin plus pembrolizumab, EV-Pembro, in the frontline metastatic settings, what are the key toxicities that we need to keep in mind and be very vigilant for those? And I think, and how do you manage them? I think this is a great question. I will refer you to the nice publication from EV-302 and EV-103 trials, as well as data from Dr. Daniel Petrilak, presented at ASCO 2024, that looked at the dose exposures and the outcomes with EV monotherapy trials, and a very nice paper by Dr. Locoutier from Memorial Sloan Kettering a few years ago looking at enfortumab vedotin toxicities. Overall, if I can just give a summary to this great question, Peripheral neuropathy, usually sensory, sometimes less commonly motor neuropathy, can be a significant issue. It's probably the most common reason why we may need to modify, dose adjust, dose reduce, or potentially halt enfortumab vedotin. So extra attention to neuropathy, good physical exam, good history, ask the patient, see if they have imbalance, unsteadiness, and of course, if they have trouble with buttons, with shoelaces, neuropathy can be an issue. It's probably more than half of the patients. It's usually sensory, but less commonly can be motor and can impact quality of life. It's hard to manage that, right? Those adjustments are probably the best way to try to prevent it as much as possible. Those reductions, those holds, sometimes permanent discontinuation of enfortumab may be needed case by case. Of course, there are medications like duloxetine or gabapentin we may use, acupuncture sometimes, mechanical devices, massage, physical therapy, all those can help manage neuropathy. Skin rashes and skin eruptions and pruritus, itching can be another issue from enfortumab vedotin and or pembrolizumab. We work together with dermatologists to have a very comprehensive evaluation of those patients. Sometimes we do biopsies if needed, but most of those skin eruptions are local, so topical steroids, topical ointments, triamcinolone, and other topical steroids can help. Antihistamines as needed for itching, pruritus. Of course, we educate the patients for potential side effects of those medications. And if something is more severe, sometimes we might need to use oral steroids. And also, we, as I mentioned before, discuss with dermatology in order to have a comprehensive evaluation. Rarely, we have to be aware that there is a important side effect, rare, called Stevens-Johnson syndrome or toxic epidermal necrolysis that rarely may happen with enfortumab. So extra attention, again, if you have a diffuse sunburn reaction, usually the reactions with enfortumab in the skin are usually mild to moderate and manageable with topical products, but as I mentioned, sometimes can be more severe. Other things to keep in mind is hyperglycemia, high blood glucose, happens in about 10% of patients, 1 out of 10, and half of them can be severe. So be very, very careful, attentive to blood sugar in both diabetic and non-diabetic patients as well. Patients with obesity may have a higher chance of hyperglycemia, but can happen to anybody at any point of time. It's usually happening early in the first few weeks of treatment with enfortumab, the hyperglycemia. After that, the classical chemotherapy-like side effects, fatigue, low appetite, taste changes, nausea, diarrhea, sometimes a sense of weakness or fatigue or weight loss can happen with enfortumab, and less likely cytopenia. So I would say pay attention to the package insert and, of course, see the patient, examine the patient, get a good history. Make sure the patient does not underreport. It's very important, so we have a full picture of what's going on and adjust doses and treatment if needed. And of course, extra attention to pembrolizumab for potential immune-related adverse events. Great questions overall. We had a great ESMO. We continue the research on genitourinary malignancies. As you all know, I have an interest in bladder cancer. We continue the trials, and we are very, very excited about the amazing results across different trials, helping our patients, aiming to live longer and better with quality of life. We definitely have a lot of work to do. We're happy about the progress, and we work hard for the future. Thank you so much. Excellent questions by everybody. Have a wonderful rest of the day.